I do not place lithium disilicate and I don't cement it. So for me, the way my mind works is if I'm cementing and not bonding, if I'm cementing, just using a GIC based cement, so I'm not relying on enamel for adhesion, why would I use lithium disilicate? Using lithium disilicate posteriorly and bonding it, excellent strength, good, it's going to be fine as long as you give it enough thickness, 1.52 millimeters, you're golden, okay? If you don't respect the thickness, or if you use cement and you don't bond it, you're going to really compromise on the strength. You're not going to get the high strength. So therefore, the same material, lithium disilicate, cemented is a completely different ceramic to the same ceramic lithium disilicate bonded. You need to know your material and the correct protocol for your material. You're not supposed to aerobrade lithium disilicate. But I know some clinicians who, whatever material they get back from the lab, they will aerobrade it. You do introduce micro cracks. Whether or not it's clinically significant or not, I don't know. But I'm one of those people that I follow the rule book for any material I use, any bond I use, like exactly how the manufacturer wanted it. I pretty much will follow that. The other thing to bear in mind is how important is it to you that this molar tooth, right, looks absolutely gorgeous. How important is it to you? And I wait for them to say their answer. Okay. And I say, okay, you want it to look gorgeous, but what if I told you that if you accept that it's going to look good but not gorgeous, it will last way longer because the chance of it breaking is way less. What's more important to you, longevity or beauty? When I was a student, like many things, ceramics were very confusing. And fast forward many years, when I qualified, they were still very confusing. What I present today in this Back to Basics series with Emma Hutchison, the Protrusive Student, is a simplified overview of ceramics and how I view them. My views are based on the courses that I've been on, the evidence that I've read, and my daily clinical practice, which makes up a third of evidence-based dentistry itself. Hello, Protrusive, I'm Jazz Galanti, and welcome back to your favorite dental podcast. Hey, the last one on extractions, I mean, you guys loved it, so thank you so much for everyone who liked it and commented. It really helps us to keep going. I was always unsure about this Protrusive Student series and going back to basics, but you guys are loving it and I really appreciate that. And me and Emma will continue to make dentistry tangible for students, but a lot of these episodes are very useful for dentists, like a back to basics, revisiting the foundations. There's something very validating about that. Sometimes you can only measure your growth when you look back and listen to an episode like this and feel that, you know what, I knew kind of everything and look how much I have grown. There's real beauty in that. So in this episode, we cover decision making in ceramics. What influences your decision? What are the main ceramics that I'm using nowadays, and do I still use porcelain-fused-to-metal? Are the protocols different for the different types of ceramics and crown materials? How important is rubber dam isolation? Is split dam good enough? And we've even thrown in some rubber dam tips in there for you. This episode, like the last one, is eligible for CE. Protrusive Education is a PACE approved provider, and we also satisfy the criteria for the GDC. All you have to do to play and collect CPD is answer the 5 questions and get 80%. That's only available on www.protrusive.app. Once you make an account, you can download it on Android and iOS, listen on the go, answer the questions, also answer the questions of the past episodes that you've listened to, and validate your learning. An opportunity to reflect, which forms part of your personal development plan. We've also got the notes from this episode written by Emma, all about dental ceramics, like a cheat sheet for any student. It does go quite deep, but it's all the stuff that you need for your exams. And that's in the Crush Your Exam section of Protrusive Guidance. Once you join Protrusive Guidance, you just have to email student@protrusive.co.uk so we can verify you're a student and add you on there. Now let's join the main episode and I'll catch you in the outro. Emma Hutchison, the Protrusive Student, welcome back. You've just had an exam. How did it go?
It was okay. It was a structured clinical reasoning exam, which was something that it's something that Glasgow, it's something that Glasgow only introduced. I think 2 years ago. It might have been last year actually. So no one really knows what was going on. So
an example question from there. That was a tough one.
Yeah, so you're basically given a few cases and you have like an assimilation time to sit in a room and look over these cases. You just get radiographs, clinical photographs, a bit about medical, social history. So you have 25 minutes per case to read over. You don't know what questions you're going to be asked, and then you go in and you've got, for each station, you've got 2 tutors or clinicians and you sit in front of them very closely actually. I thought they were going to be a bit further away across the room, but you were sitting right in front of them and they just kind of grill you on your treatment plan. you know, if it's oral medicine, they'll ask you questions about histology, things about medications as well. Like we had a patient that was on warfarin, so they're going to ask about all the INR, things like that.
You knew that. You knew all that, right?
Yeah, yeah, it's hard because you have no idea what's going to come up. So a lot of it is reading over your guidelines, SDCEP, American endodontics, things like that. So it's very intense. It's very intense, but I'm glad
Go.
it's over.
Which was the question that stumped you?
So you get your topics 2 weeks in advance. So we were restorative and orthodontics as well. And
Cool.
for restorative, I thought I was going to completely fumble because it is such a huge topic. With ortho at my level, you know, in dental school, there's only so much that they can ask you, I suppose. But the ortho one was really, really tricky. They wanted very specific answers. It was kind of good cop, bad cop. It was very
It was
intense.
all surrounding that specific case that they gave you, right?
Yeah, yeah. So we had a case of a little boy who was like class 3. You had to go over all the treatment plans, which, you know, in theory I do know, but just it was quite intense. But everyone in my year sort of felt the same, so we'll see how it goes.
With dental exams, I couldn't read it when I came out. Like when I did maths back in the day in A-level maths, right? I was pretty good at maths when I wanted to be. Like I went into my C4 last exam knowing that all I needed was 13% to get my A. That was the highest grade at
Yeah,
the time. Now they got like A star or whatever now in A levels, but I
yeah,
needed 13%, right? So I completely didn't study C4 at all. I just knew that I can just get
yeah.
13% like by writing my name. So I got like 55 in that, right? And everything else I got like 99s and hundreds basically, right? So I was when I was wanting to be, I knew I could switch it on for maths. And then
Yeah.
so when I come out of a maths exam, I knew, okay, I've aced it or I flunked it. I knew, right? When it came to dental school, I was like, I had no idea, especially with those
Yeah,
kind when you're being interviewed and oskied. And sometimes I
yeah.
come out and think, oh my God, I flunked this. And then I surprise myself. Like it's difficult to read.
Yeah, it's really difficult to read. And they said we had a sort of recap of it, and they were saying, you know, we did purposefully examine it a bit harder because when it comes to our case pres, and we've got another clinical reasoning exam later on in the year, I don't know, they wanted to give us a bit of a fright, I suppose. They said in hopes that the real thing, you know, the big exams that are a lot more heavily weighted will be a bit nicer.
It's a good
So we'll
approach, you
see.
know. They give you a
Yeah,
real tough time so that the actual
yeah,
thing will be easier and nicer.
yeah,
So that's good.
yeah,
Well, today's
yeah.
topic is ceramics. Our last episode, extractions, went down really well. Everyone loved it, so well done, Emma. It was great questions that you'd asked. Everyone loved the avocado analogy, but more importantly,
Yeah.
did you resonate that analogy? Have you done an extraction since? Maybe you haven't. I don't know. You tell me.
You know, I actually haven't done an extraction since. I was on a good roll with extractions and now it's completely stopped. So hopefully in the new year.
But right now you know what an application point feels like. Now you know to liken
Yeah.
it like an avocado and stuff, and then the removal of a nut. So that was good. I enjoyed that
Yeah.
very much. And today it's ceramics, right? So
Mhm.
ceramics was a topic that, again, I mean, so many topics at dental school confuse you. Most of them do, but this is in materials. Like I was okay at memorizing about lucite reinforced and then the history of ceramics and stuff. But at the actual practical element of delivering
Yeah.
ceramics and actually what do you actually do in the real world, I had no idea.
Mhm.
Like really, it was very heavily emphasis on PFMs. Like your exam was a PFM, porcelain fused to metal, or metal MCC, metal ceramic crown, as some people call it.
Yeah.
And so, I've hardly done many since qualifying of those crowns. Yeah, still do, and we'll talk about the indication for that. But nowadays, in the world of all ceramic, what I was
Mhm.
being taught was already quite outdated. So it'd be interested to know what kind of crown preparations are you being taught? What kind of materials are you being taught to use on your patients?
Yeah, so I think in Glasgow we're still learning about metal ceramic crowns, how to prep them, but we are also learning about, you know, all ceramic alternatives, I suppose. So my first question was going to be about, do metal ceramic crowns still have a role in dentistry today, like especially in private dentistry, I wonder, or
Mhm.
have they largely been replaced by all
The
ceramic?
answer is they've largely been replaced, but they still have a role. To get
Yeah.
PFMs like working well, right, and
Mhm.
looking good, you need space. You need that 1.5 to even 1.7 millimeter if you're making it look really
Mhm.
aesthetic, right? So you have the metal layer, the opaque to block the metal layer, right? Then the ceramic, and to actually give it a good bulk to make it look pretty, it needs a
Yeah.
lot of space. And so that
Mhm.
ends up being a very invasive preparation. We're trying to move away from that. So to do a proper PFM that looks good, it still has a place, but maybe not so much. And so the time that I
Mhm.
would use it, and a lot of today is very much, if you had a different podcast host, you'd be getting different answers. So a lot of it is based on my opinions and experiences. And I think everyone's got a story, everyone's got experiences that have shaped them, that shape their thinking. So for me, the time I use PFM nowadays is if I've got a severe high force bruxist patient and I would like to have a metal occlusal, right? Because it's got very good wear properties. It's got very good strength and longevity. I can be more conservative by having metal only, right? So I don't have to drill as much. But then maybe on the facial, I'm not going to go for a super aesthetic. Maybe it's a first molar, maybe it's a second premolar. And so I'm still going to be a minimal prep and accept that it's going to be an ugly looking PFM. Like only the buccal will have porcelain, but it'll be a very thin porcelain and it won't be very aesthetic. But for this more functional tooth wear case, is going to be completely adequate. So that's where I'm using it at the moment, whereas we've pretty much moved to zirconia and lithium disilicate, which are the two main types of ceramics.
Yeah. So another question that I did have was, what factors determine your choice of ceramic material for, I'm going to say largely for posterior versus anterior restorations?
Okay, it's very simple and it doesn't change so much depending on anterior versus posterior for me.
Okay.
So put it this way. If I know that I need to go indirect, right? So I've decided, and so again, recap a little bit. For posterior, you know that it's too ambitious to go direct here. You're literally having to do an MODBL. You're going to find it difficult to get good contact points. Maybe the tooth is root filled and you need to cover over the cusps so that the cusps don't bend and flex and break. So there's so many good reasons sometimes to go indirect. So when we made that decision that we're going indirect posteriorly, if I've got enamel all the way around, I've got a decent amount of enamel, and the tooth isn't so destroyed, it's still got some enamel to bond to, my substrate to bond to is good, I will go for a bondable partial coverage restoration. So do you know what I mean by partial coverage?
Like an inlay or an onlay?
Yeah, not so much inlay in this scenario I'm talking about. An inlay is basically, you could have done a DO composite, but you asked the lab to do it instead of you. That's essentially an inlay, right? The onlay more like covering over like an overlay. Like you're covering over the cusps, okay, and you're bonding to the enamel, the ceramic, etchable ceramic, which we talk about, okay, lithium disilicate, right? I will go lithium disilicate because it's conservative. Why should I have to remove any tooth structure that I don't have to? If I can bond to the ceramic, it has no retention form. It's got a tiny, teeny bit of resistance form, and we'll talk about that. But I'm relying on the quality of the enamel for my bonding. It's very conservative. All you have to do is remove the old MOD amalgam, okay? Take the cusps down a couple of millimeters, and that's your prep pretty much done. You just smooth it and you block out the undercuts of composite. So the prep is enjoyable. You feel like you're saving so much tooth structure. And if I've got enamel, I will use lithium disilicate. Why lithium disilicate? Because it's got very predictable bond. I will not use zirconia partial coverage restorations, even though nowadays some clinicians are. And I've asked this to real top dogs, okay? I've asked this to Dr. Nasser Baghi in 2018, is a top dog in the US on zirconias and ceramics. Recently, where was I? I asked Chris Orr this question at BACD just this year, 2024. And I said, when these zirconia restorations are showing such promising data that we can bond to them, should we be moving away from lithium disilicate? He's like, no, we have this beautiful material, lithium disilicate, that is predictable and it's got so many advantages. Let's just stick to this. He's not yet moving on to zirconia posteriorly. So if posterior and has good enamel, I'm going Emax, which Emax is a brand, by the way. It's a brand of lithium disilicates by Ivoclar, okay? The other one is Lissi by GC, okay? So they are both examples of lithium disilicate. Now that same molar that has got less enamel, maybe the mesial and distal caries is really deep and you're on dentine now, okay? And you have just generally less tooth structure. I'm instead going to go for zirconia. I'm going to go a full crown all the way around 360 degrees. And I will prepare, and this might blow your mind as a student, but something called a vertical preparation. Now, you being the Protrusive student, you have access to all my webinars, you have access to everything. You should eventually do verti-prep for plonkers. It's something that teaches everyone to do their first vertical crown. But essentially, there is no shoulder, there is no chamfer. You've hardly drilled into the tooth. It is a super conservative way to deliver a crown in a really lovely conservative way. So I'm getting all the benefits of having retention and resistance, but I'm not sacrificing much more tooth structure to get that. So if posteriors, it's either lithium disilicate if I have enamel, or zirconia if I don't have enamel. And then, like I said, in that severe bruxist patient, if I want metal occlusal, I might go PFM, but that's rare. Any questions on that before I move to anterior?
No, it's a different take to what we've been taught at uni, but it's
Let's
interesting,
talk
like
about
it
that.
makes
What have you been
sense.
taught at uni? I'd love to know.
So a lot of the things we talk about at uni are purely based on like strength and aesthetics and how certain ceramics are better anteriorly because they've got good aesthetics, but then posteriorly you want to use something else because they're stronger, they're more robust.
Can you give examples? Do you remember the names of ceramics? Can you give some examples?
Is
I'm
it
putting you on the
lithium
spot, so don't
disilicate
worry if you don't
that's
remember. It's okay.
that's
I hardly
okay.
knew anything about ceramics when I was at your stage, so you're doing great already.
Is it lithium disilicate that's better for like translucency in the anterior, or have I got that the wrong way
No,
around?
no, it's got different ingot types basically. So it's like high
Yeah.
translucent, low translucent. So yes, lithium disilicates can be quite nice looking. A lot of
Yeah.
veneers are done in this type of material, but it is totally appropriate to use posteriorly as well. Let me say again, it
Okay.
is totally appropriate. And here's the magic bit now. Probably the most important part of this podcast will be this: providing you have enamel, because if you have enamel, you can bond. What I don't do is I do not place lithium disilicate and I don't cement it. So for me, the way my mind works is if I'm cementing and not bonding, if I'm cementing, just using a GIC based cement, so I'm not relying on
Hmm.
enamel for adhesion, why would I use lithium disilicate? Do you know why?
Yeah.
Do you know why I'm against using lithium disilicate? The magic property of lithium disilicate and feldspathic porcelain veneers, the magic of what happens when we bond them.
No.
And that's totally fine. I wouldn't have known at your stage, but the main lesson here is feldspathic is a type of ceramic, basically. It's a very beautiful ceramic,
Hmm.
traditionally used for veneers. Not so much
Yeah.
anymore because the number of technicians who are skilled at this is less and less and less as we're going more
Hmm.
CAD CAM and whatnot, and then labs are going more digital. But essentially, these veneers are beautiful, but they are weak.
Yeah.
Something from my mind, I remember like 90 megapascals, let's say, right? So they are weak compared to 250, 300 megapascals of lithium disilicate. So they're weak, but they're beautiful.
Hmm.
But once you bond them to enamel, they are so strong. It's a
Right.
bit like a tile, a glass tile.
Hmm.
Like if you drop the tile, it's going to break. If you actually glue that tile on the floor, it is strong.
Yeah.
That was the analogy that was given to me when I was a student. I still remember this basically. So
Hmm.
using lithium disilicate posteriorly and bonding it, excellent strength, good. It's going to be fine
Okay.
as long as you give it enough thickness, 1.52 millimeters. You're golden, okay? If you
Hmm.
don't respect the thickness, or if you use cement and you don't bond it, you're going to really compromise on the strength. You're not going to get the high
Okay.
strength. So therefore, the same material, lithium disilicate, cemented is a completely different ceramic to the same ceramic lithium disilicate
Mm.
bonded.
Yeah. Okay. I didn't know that. I'd never like it probably has come up in lectures before, but it's not something that I've ever really thought
So
of
that's
like
why I
that
don't do
before.
lithium disilicate cement because I've got this wonderful material, super strong, called
Hmm.
zirconia. And that
Yeah.
is really amenable to cementing, and I can get my
Hmm.
retention and resistance form because I've decided I don't have much enamel here. So I'll do a
Yeah.
vertical preparation crown posteriorly using zirconia, which I'm going to cement.
Hmm.
You could be fancy
Okay.
and bond it, but why complicate the protocol?
Yeah, that's true. No, that makes sense actually thinking about it. I've never heard the analogy with the tiles as well
Mhm.
and how it's a totally different thing once it's actually glued onto the wall or the
They
floor.
behave differently.
Um,
But I mean, the other key
yeah,
lesson here is giving enough occlusal clearance. So the biggest
yeah.
mistake we make when giving occlusal clearance is we don't give enough. And we think we've given
Hmm.
enough, and then gets a lab, and they're kind of literally squashing and squeezing this material in. Okay, and I don't know why dentists are so afraid, myself included, back in the day, like of trying to be as conservative as possible occlusally. Yes, it's good to be conservative, but with a lot of these broken down teeth, the occlusal part is like composite. The tooth is
Yeah.
lower down, all right? So I'm happy to sacrifice more tooth structure, have a more thickness of crown material that will really make
Yeah.
it unbreakable.
Hmm.
So
Hmm.
just remember that. And the common place that we will under reduce is the fissure. The actual fissure
Okay.
itself, okay, is the most likely area that will be under reduced. And the other common mistake is, let's say you're doing a premolar crown, right? And what
Hmm.
you do is you end up flattening the occlusal. You don't follow the same anatomy, right? You see like the cuspal anatomy basically. It goes
Yeah.
rise and fall and rise. If you don't respect that and you flatten it, great. The
Hmm.
cusps have been reduced nicely, but that middle portion, you've hardly reduced it. And that's a big,
Yeah.
technicians, that's the biggest issue they have. So remember, when you're doing the occlusal reduction, follow the anatomical form of the tooth. So it's a
Yeah.
uniform reduction, and then you're going to get enough thickness where it matters, because that's where the fossa of the tooth is. That's where the opposing cusp will put the occlusal load down. So if you want ceramics that are not going to fracture, you got to do that. The other thing which we haven't talked about, which you're probably going to ask about anyway, but do you know the difference between something called like what I mean when I say the term monolithic and when I say layered? Do you know the meaning of this?
Is this the way that it's like milled or put together or constructed?
Not quite. Like once you have that lithium disilicate, right, that block of like is ready to go on, right? There's two ways to
Yeah.
treat it. One is you accept it how it is,
Mm-hmm.
and it's a really strong material, okay?
Okay.
But it's not as beautiful as it could be. We can
Right.
make this. So let's talk about an anterior crown, right? So if we're going to do a lithium disilicate upper right central crown, central incisor, okay, crown in lithium disilicate. If you have a monolithic, which means that it's just the pure lithium disilicate material,
Yeah.
that kind of like a one shade, right? It's got some translucency, but it is like the one bulk basically, right? Versus the same crown, but what you do now is you shave the buckle of the crown down a bit by 0.5 millimeters, for example, and then you add some beautiful weaker ceramic on, layer it. You put these effects in, okay? That second one, that layered porcelain fused on top of it, basically, is going to look so much more beautiful. You're going to put those effects in. It's going to look gorgeous, okay? But it's now weaker because now you have an interface between the monolithic ceramic and the layered ceramic. And therefore, another golden rule here is, why would you do a layered ceramic posteriorly? Why? Just don't do it, okay? The reason why zirconia had a bad rap initially, and also Emax lithium disilicate had a bad rap initially, is because dentists were doing these gorgeous restorations posteriorly, and they were layered. So they were actually putting this beautiful, weaker ceramic in the occlusal loading area, and guess what was chipping? It was delaminating. It was chipping away. A bit like, maybe you've seen this, Emma. Have you seen PFMs where the porcelain's broken away and the metal's left behind?
I've never seen it, no, but yeah, it can happen.
Not even as your role as a nurse? Do you remember not seeing it as a nurse, maybe?
Not that I can remember. No, not that I can remember.
Fine. So it's the same thing. Like the ceramic is bonded to the metal. In the same way, the beautiful ceramic is bonded to the monolithic, stronger form, basically. So anteriorly, for some patients who are high force, maybe they're bruxist, you can still do a monolithic Emax or monolithic lithium disilicate. It will still look good, maybe a 7 out of 10, but if you want to aim for a 9 out of 10 plus, you want that same ceramic, but you want it layered, basically. And so that's the difference. So anteriors tend to layer for most patients. Posteriors keep it monolithic. Even when it comes to zirconia, yes, the downside is they look very opaque. They look a bit too white, right?
Yeah.
But it really depends. It's a conversation I have with my patients. Okay, how important is it to you that this molar tooth, right, looks absolutely gorgeous? How important is it to you? And I wait for them to say their answer. Okay. And I say, okay, you want it to look gorgeous, but what if I told you that if you accept that it's going to look good but not gorgeous, it will last way longer because the chance of it breaking is way less? What's more important to you, longevity or beauty? And you can't have both sometimes. And I let the patient decide, because that is then the ultimate level of consent.
Yeah. And would that still be your same protocol for patients that are heavy bruxists?
Okay, so heavy bruxist, so let's say that I'm treating heavy bruxist basically. Some schools of thought say that because you're treating heavy bruxist, like your molars, which take the highest force, because remember the masseter muscle is right there, right? The medial pterygoid muscle is right there. It's right by the joint. So the forces felt in the molar region are significantly higher than the forces felt on the anterior region. So then people say, oh, do gold on the second molars, right? Do gold restorations, okay? They're longer lasting, they're more forgiving, or maybe do a milled cobalt chrome, something metal is considerable. And I get that, but the studies would say that as long as you give your ceramic enough thickness, it will fare well, even in bruxis. And another thing with bruxis is that if it's a true pathological bruxis, then they spend all that money, you want to protect it with an appliance. Things will just last longer. It's something that we need to accept that, okay, some patients will need protecting. But when it comes, even without protection, you give enough thickness, the ceramics will survive. But again, posteriors, I will go monolithic. I will not layer. As I say, no need to layer, especially on a bruxist.
Yeah.
You're just asking for trouble. You're asking for things flaking and breaking away.
No, that makes sense. And that's largely what we've been taught at Glasgow as well. We've went over gold crowns and things like that, but not in too much depth really. But no, that definitely makes sense.
The last time I did a gold crown on a second molar, guess how much the lab bill was?
Cool. I don't know.
It was like £400
Yeah.
lab bill.
Yeah.
Absolutely crazy. Like the price of gold is so high. And so I went to
Yeah.
a British Society of Restorative Dentistry lecture once, and there's a chap, I think his name was Phil Taylor. I think, might be getting it wrong here. And he was a restorative consultant, and he suggested that he long time ago, he moved away from gold because of the cost reasons to a very good alternative, which is milled cobalt chrome. Okay. And
Okay.
chrome is very kind to enamel. Okay. It is stronger and more rigid than gold, which actually is a negative property. The strength of gold that is because it's softer, it adapts nicely
Yeah.
to the opposing dentition, whereas the cobalt chrome is you have to get the occlusion a bit more spot on. It's a bit less forgiving, but it is a very good long lasting, and you can still be very minimal in your prep basically. So I have been doing a lot of milled cobalt chromes when I want to do metal in the posterior.
Yeah, I've never heard of that, the milled cobalt chromes before actually. But is there a lot of labs that still do like gold crowns? Like they're definitely still out there, but
Yeah, oh, they're
very
definitely still out
expensive.
there, but
Yeah.
be prepared to prep as minimally as possible. Otherwise, the lab bill will be
Yeah.
crazy. So add more core. Make sure you max out on the core, and then you prep back to do the bare minimum, basically. But
Okay.
jokes aside, the labs will do it. It's still a fantastic restoration, right? And a lot of dentists will, when dentists in their 50s and 60s, when they need a crown on their busted molar, they will ask for gold. They will ask for a 3/4 gold crown or whatever. It's a beautiful material. And what really inspired me to get into toothware was looking in someone's mouth once, and I was a fine year dentist student, and just seeing this beautiful posterior gold work. And that really inspired me to go more to
Yeah.
restorative.
My next question was about challenges when we're fitting these types of restorations. So what are like the most common challenges and how do you overcome them? Because I know in practice I've never done direct restorations myself yet. Hopefully soon. Indirect, sorry. Am I getting that right?
Yes, so
Yeah.
things that are made
Yeah,
outside the
yeah,
mouth,
yeah.
indirectly spot on.
Yeah, so I've not done any indirect restorations yet, but I know in practice, like I've seen etching with acid and air abrasion. Like, are these necessary steps, or are these steps that only some people will take in order to help prevent challenges?
Okay, excellent question. Okay, and you need to know your material. You need to know
Hmm.
your material and the correct protocol for your material. You're not supposed to air abrade lithium disilicate, but I know some clinicians who, whatever material they get back from the lab, they will air abrade it. You do introduce micro cracks. Whether it or not is clinically significant or not, I don't know, but I'm one of those people that I follow the rule book for any material I use, any bond I use, like exactly how the manufacturer wanted it. I pretty much will follow that. The other thing to bear in mind is you need to have the right tools in your clinic to be able to follow those rules. So, for example, if you are going to do a resin bond bridge or maybe even a zirconia resin bond bridge, okay, and these for something like lateral incisors, in the right case, they last so well. The Matthias Kern data is brilliant, but you need to follow the APC protocol, which means you do air particle abrasion. You use a zirconia primer. So if you don't have a zirconia primer, don't even bother doing this, okay? And you use a composite resin cement, basically. And so you need to follow, to get the success that you see in the papers, you need to follow the protocol exactly. So the most common mistake I see is lithium disilicate restorations, okay? The dentist doesn't know if the lab has etched it with hydrofluoric acid or not. They don't know,
Yeah.
okay? And then they are either just thinking, oh, the lab did it and I'm not going to do it. So maybe it's never been etched, okay? And the whole way that the lithium disilicate bonds to the enamel, okay, is because you want this like tiny little porosities in there to kind of like etched enamel, right? You want the etched ceramic to actually give you that bond strength. So you need to work with your ceramic properly. So speak to your lab technician, find out who's taking care of the etching. Once you've done the etching, you want to make sure you're not air abrading something like lithium disilicate, and then you're following your bonding protocol to a T. When I'm doing my vertical zirconia, right, because I'm not bonding, we call it plonking. We're plonking this on. It's so easy. Cotton will roll, okay, dry the tooth a bit, but I use something called Clean to clean out the ceramic, but that's not so important. So I've got my nice clean zirconia, okay. I'm just literally putting some cement inside, I'm plonking it on my thumb, okay. It is so easy. Okay? As long as there's no bleeding or anything, it is so easy. When I'm doing a lithium disilicate, I've got rubber dam on. No compromise. Rubber dam has to be on, okay? You've got to make sure they can access the margins beautifully. I got PTFE tape on the adjacent teeth, make sure I don't get any etch on the adjacent teeth. I'm following everything. You're preparing the ceramic in a certain way, including the silane. You're preparing the tooth in a certain way. You're aerobrading. You're making sure the aerobrasion doesn't touch the adjacent teeth, otherwise they're going to stain in the future, all these things. So bonding is more technique sensitive. More can go wrong. But if you follow the steps properly, it is incredibly predictable and it's a very fun appointment. I love both. I love both plonking my zirconia crowns and I also love spending a bit more time. So for zirconia crown, it's half an hour. For a lithium disilica overlay restoration, it's 45 minutes to account for the extra steps. Treating the ceramic, the rubber dam isolation. And so the main answer here is know your material, know the best way to treat it. Make sure you've had a conversation with the lab to know how they are treating it. And therefore there's no confusion and you can follow the right protocol.
Yeah, definitely.
Is there anything about a specific protocol that you want to know? Or
one question I did have actually, see when you're saying you've got rubber dam on in that scenario, what teeth are you, like, is this like a split dam? I've just never seen this before in practice when someone's got rubber dam on when they're cementing a crown or bonding a crown, whatever. I've never seen that before. Like, are you doing a split dam? What teeth are you bringing through? Like,
okay, good question. Okay, so some colleagues will say that split dam is absolutely fine because then what you're kind of reducing is you're reducing that mouth breathing element of the patient. Okay, so split dam's good, but I don't see the point of split dam for most cases because the gingiva is still there poking out. Okay, and if you've got like most of the times when I'm replacing these MOD amalgams, I'm doing these ceramic overlays, you're literally equigingival or very slightly subgingival. Okay, right, and so if you're using a split dam, your papillae are just contacting your margins, or there's fluid, gingival clavicular fluid, or sometimes blood. So I'm not a fan personally of split dam when it comes to bonding of my overlays. And what I will do is I'll do a quadrant isolation. So if I'm doing a first molar, I'll do a quadrant, so maybe something like an upper lateral all the way to the second molar. I'll make sure I've rehearsed the restoration when the rubber dam is on to make sure I've got a nice path of insertion. I can seat it, I can locate it well. I'm then following all the steps for getting the onlay ready, the overlay ready. I'm following all the steps to get the tooth clean and ready. And then while the rubber dam is on, and what the rubber dam does, it suppresses your papillae. Now you can see clearly, you can walk a probe around your margins, okay? And it also makes it clean up easier as well, basically, because then you're not, because as soon as you start cleaning up, you poke the gum, it's going to start bleeding. The rubber dam will protect you. It'll give you some protection, basically. So I'm not a big fan of split dam when it comes to bonding my ceramics. You'll find, remember, Emma, you got access to all of this. And those dentists who are listening, watching, I've got example videos of through POV, point of view. I've got my loop camera on. I'm bonding these lithium disilicates exactly how Emma has described it on the rubber dam. So I've got all those videos in the premium clinical video section of Protrusive Guidance. So do check those out, guys.
I think a lot of students can get quite frustrated with rubber dam, and I think it's because we've not yet seen the benefit that it can have. You know, we've not been doing this long enough to see the failures when you don't use it.
Oh, Emma, when I was in third year, I remember being in a locker room and there was a dentist, I'll name him Michael Spencer, with me and him in the locker room. I firmly remember him being there in the locker room, and I said to him, when I'm at dental school, I'm never going to use rubber dam. I said that to him. I said, cotton roll all the way. I said that to him, right? And now, although I've relaxed in the last couple, I was like very much rubber dam police before. I've relaxed a bit because I've now found like greater curve matrix, which gives such a wonderful seal that I need it less and less. So as long as the patient's not a mouth breather and it's an upper tooth, I can pretty much do a lot of it using a nice metal shield, basically, as long as a patient or mouth breather. If I'm working on the lower arch, I'm pretty much always using rubber dam. That's my recipe at the moment. And for me, Emma, it's like, forget the increased bond strength, forget the risk of contamination, forget the access to the margins and suppressing the papillae. The main benefit of rubber dam for me is relaxation. It's a stone. That rubber dam is on, the patient can't speak. Amazing. Fantastic. Okay. The rubber dam is on. Okay. And I can turn away and know that I can sleep well at night knowing that no one licked anything. I can drop my onlay and it's fine. The rubber dam's going to catch it. Comfort for the patient, I think, is good. I just find it's a happy place to be. Rubber dam is on. It's just a beautiful, happy Zen zone. That's my number one benefit. It's very selfish. I use rubber dam because it reduces my stress.
No, the few times that I've placed rubber dam as well, like it's very, very frustrating. Like I'm not good at it. But once
you're
it's
not good
on,
at it because you haven't done it enough. And you're probably using the crappiest dam in the world, the green one. right?
I think we actually do have the thick blue ones in the dental hospital, or they give us that for OSCEs anyway.
Okay, okay. Well, okay. Again, so posteriors, and again, everyone's different with what they recommend. For me, posteriors,
Mhm.
I like to go medium thickness.
Okay.
Anteriors, I go heavy, right?
Yeah.
Because anteriors, often you want to suppress the papilla a lot because you're doing like bonding and stuff, that kind of stuff. Whereas posteriors, you
Hmm.
want it easy to go on, right?
Yeah.
So medium is a thinner. So when I was learning, I was using that horrible green dam, right? And
Yeah, I know
it
the
just
one you're
was
talking
ripping.
about.
And then the other terrible one's that purple one, that ribbed purple one. They call that the devil's
Yeah.
condom. It's the party with that. Basically, you punch one hole, you punch one rubber dam hole in it, and you put it over your head. I think someone called John Cowie, the endo chap in Bristol, mentioned it on Instagram. It's hilarious. You put one hole in it, and you can literally poke your head through
Yeah.
a rubber dam with that one hole, and it's a nasty rubber dam. Okay, and so
Yeah.
really you want to go something like Nick Tone. I love the Uno Dent stuff, just
Hmm.
some thin stuff that doesn't tear. It greatly, the right tools for the right job, it greatly improves your
Yeah.
stress, it reduces your frustration. When rubber dam becomes
Hmm.
easier, once you've got a system of doing it. For example, I find that dentists, when they're struggling with rubber dam, they're trying to do too much themselves. When I'm doing rubber
Hmm.
dam, it's a four-handed job. Okay. Once I've got it over my clamp,
Yeah.
I'm just setting it in place. My nurse Zoe, she knows she's going to get a flossette out. Flossette, not floss, because guess what? All of my nurses have got fat fingers and they struggle to floss my patient's teeth. So you give them a flossette, okay, right, and they can easily, right, just go through
Yeah.
and take that rubber dam with it. Basically, okay. I joke about the fat fingers. They struggle, right? There's four hands in there. It's difficult. You get
Yeah.
a flossette in, you remove the hand out of the equation.
Yeah, and I've never seen anyone do that. Like, I struggle so much. You feel so silly as the nurse as well, like trying to floss that through. You're like, I know how to floss, but it's really, really difficult.
Angulation,
But
everything's different. But when you
it's
use a
so
set, it's
tricky.
so much easier.
Yeah, yeah, and we used it's the Unodent one that we have at uni as
Oh, that's a
well.
good
I
one.
think we used to have the purple one
Oh,
before, but it just wasn't good. So
oh. But that's good. You got the good stuff. I would say use it more
yeah,
when you next have some direct restorations. Please, I really want you, because you got all the time in the world as a student, right? I
yeah,
want you to go through that difficult period of using rubber dam. Quadrant,
yeah,
isolate the quadrant. Watch my webinar. I've got 30 videos on Protrusive guidance,
yeah,
tooth by tooth, like 5 minutes, 15 minutes of case I really struggled in,
yeah,
unedited, raw footage of me putting on rubber
mhm,
dam. Revise all of those, okay? And I want you to
yeah,
use that technique. And I want you to promise me that you're going to use rubber dam, because
yeah.
now is the best time. If you start practicing now, wow, you're going to absolutely sail.
Yeah, definitely. I think it's so frustrating, but once it's on, it's good. And once you're good at it,
Buy a
you're
pack of
good at
flossets,
it,
because maybe you don't have it in clinic. So take your own flossets
Yeah,
with you,
no.
okay? You got the Uno Dent rubber dam, which is great, and follow the instructions in those videos and the webinar. Trust me, like you'll have such a less frustrating time.
Yeah, and hopefully I get to do some indirects soon,
Even
because
just direct. I want you to do it for composites,
yeah,
composites as well. That's where you practice.
yeah, yeah, definitely. They're quite big on rubber dam in Glasgow, so
Good.
it's good. My next question that I did want to ask you, Jazz, was about intraoral scanners. We have one in the dental hospital to let the students play with. I'm sure it's on the staff clinics probably.
I can imagine all
Um,
the things the students have been scanning.
yeah, taking
Including their
us like
nose,
half
the
an
hand,
hour.
all that sort of funny things.
Yeah. Do you think, like in your practice, like in your surgery, is an intraoral scanner like an essential for you, or do you think it's very much possible to achieve the same results with traditional impressions?
Oh, I mean, impressions are king. Like, impressions are great.
Yeah.
But the question really should be switched. Is it possible to achieve the results with
Mm.
digital, that the good results
Yeah.
we've always had with analog? And the
Hmm.
answer, I think, is yes in most cases. But you have to remember a few rules. When you're using something like silicon-based impression materials, because the flow of
Hmm.
it can go under the sulcus, it can capture the details.
Yeah.
With a scanner, you can only capture where the light goes. And so, with
Okay.
digital techniques and scanning, you need to be more aggressive with your retraction core, with your
Hmm.
suppression of the tissues. Tissue management becomes more complex when you go digital. Tissue
Yeah.
management is easier because the light bodied silicon will flow in those areas and will save you. So
Okay.
analog is amazing, but digital with these quality scans, having like Prime Scan, that kind of stuff, they're really, really great. I use a scanner which is not that as good for restorative. I use the iTero. I don't care if I'm saying brands and stuff. It is what it is. They're good for Invisalign and that kind of stuff. But the one I use at the moment is not wonderful for restorative. I've
Okay.
been using it fine. I just have to then take extra time and really suppress my tissues and try and spend more time get as the best scan as I can. When it comes to subgingival areas and especially vertical preparations. I went on Marco's course in Sicily, and he showed me my own scan. Like what the technician sees with his scans, sometimes it will make you cry. Impressions for subgingival areas and vertical preparations is still king, and scanners are still catching up. But for things that are supragingival, scanning accuracy and the ability to produce really good restorations with a good fit is fantastic now. So it depends on now if you're working subgingivally or supragingivally. But the answer is scanners are pretty much there, but they still have a bit more improving to do.
Mm-hmm. Yeah. Do you think impressions will ever, I don't know, not be a thing?
I think eventually they'll be phased out. I think so. I mean,
Yeah.
the amount of impressions, I would love to speak to a technician and find out the amount of technicians that are getting in analog work and what percentage of that work it is. I'm sure it's declining rapidly at the moment. I'm sure there's still niche scenarios where impressions are king and analog is king.
Yeah.
But most indications, even dentures are going very digital, believe it or not. So digital is the way forward. There's still, for the few, sometimes you use your analog to complement your digital. So I don't think it'll be fully obsolete, but I think they might be the 5-10%, whereas the digital will be the 90%.
Well, that's good because I'm rubbish at taking impressions. So.
You'd be rubbish at scanning as well. You think it's easy. The first iTero scan I took took me like half an hour. Now it takes like 3 minutes. But it's like a steep learning curve with everything.
Yeah, definitely. But no, that's interesting. That's interesting. The last thing I did want to ask you was about the lab. And I know that you're very specific with your labs. You've got great communication with them. Like, are there specific challenges or preferences that you have when working with labs on ceramic restoration specifically?
It's a journey you go on with your technician. And a great piece of advice that was given by my technician Graham, who came on the podcast a few times, is try and find a technician who's like a similar age to you, and you work together and you send all your cases to that guy or gal, and then you communicate over WhatsApp and you grow together. There's something really beautiful about that. And then dentists, when I say to dentists that I help to train my technicians to improve this element of it, they think, but Jazz, you're a dentist. What do you know about the technician side? How can you train them? But when you speak to a technician, they're very grateful. Equally, the technician trains me. And he tells me, he shows me my scans that, you should have smoothed this amalgam and the mesial, like you didn't, and it's made it more difficult for me. And you're constantly learning together. So firstly, the lesson here is communicate with the technician. Even if you're using a bigger lab and you don't even know the name or the face of the technician that's making your work, the more information you give them, the better. So if you just say Emax, crown, A3, upper left 6, okay, how much care, love and attention do you think the technician will give? They're just going to put it at the bottom of the pile and they'll make you something that's acceptable, hopefully. If you say lithium silicate overlay restoration, upper left 6, shade A3, but it's got hints of, a higher chroma cervically. My mesial margin was a bit questionable. Please let me know if it was acceptable or not. Please give me some feedback. Okay, so you're inviting them to give you feedback. There were shim stock holds on the upper left first premolar, second premolar. The second molar wasn't holding shim, but the third molar was. So they now can verify the bite. Okay. And then you say that please follow the cuspal inclines of the adjacent teeth because this patient's got group function. And I'd like to keep that because we're not changing anything about that, basically. Try and aim for a couple of contacts with the opposing tooth. Where you see the cusp of the opposing tooth, try and create these landing areas in this molar. And so when you give all that kind of information, right, you're going to get something much better back.
Yeah. And who I have on a Friday morning on my pros clinic, Mr. Fogel, he was a dental technician before he was a dentist.
They are the best dentists.
And he loves pros. He loves it so much. And we were doing a tutorial about I can't remember what it was about anyway.
Student, I have no idea what it was about. It was something. I just showed up hungover. It was.
He was talking about inviting your lab technicians to critique you, and vice versa, and just about like be open.
Some technicians are scared to critique their dentist because they're thinking of losing business, losing a client. But when you give them from the get-go, from the get-go, I tell Graham, listen, don't be about the bush with me. If I've done something not to your standard, you got to tell me. Equally, 100%. When you cock up, and he does, and I cock up sometimes, and when he drops the ball, I'll tell him. I'll send him, because I'm recording my videos of me doing the procedures. Unfortunately, he gets the crudest feedback. He sees me struggling to fit the crown that he made, and he'll see that, I kind of overdid it on that mesial contact. And he gets to see video footage. Or very rarely, but sometimes I reject a crown because there's an open margin there. And you get to see my photos and videos. So it's painful being a technician sometimes when you got clients like me. But equally, when I've done something wrong, he'll tell me. And it's beautiful to grow like that. And our mistakes are getting less and less, and we are able to really serve our patients better.
Yeah, definitely. And I think it goes both ways. Like, I think dentists, well, students anyway, are often scared to speak to their lab, or if something's not gone quite right, to talk to them about that. But Mr. Fogel was saying, he's like, if you phone up a lab, he's like, I've never spoke to a technician on the phone that wasn't very pleasant. You know, like, it's like no one wants to lose business at the end of the day, and you want to have a good technician. So yeah.
I was always taught that a average dentist and a good technician will do very well. So pick your technician wisely, pay a little bit more premium for your technician, basically get a good technician, and they will save your bacon.
100%. I think that's all the questions that I had today, Jess.
Thank you so much. And I'm excited for you to, start doing some rubber dam dentistry. I would love for you to do it and feedback, see how it went. And yes, the first 100 times you'll be frustrating pulling your hair out. And the 101st time you're like, you know what? Today I isolated and I didn't cry while isolating. It was good, right? So, it just, you have to go for it. Please, you have to go for it.
Yeah.
And then also when you start coming to your first indirect restoration, let's have a chat. Tell me what material you got in mind, what your technician suggested, what your tutor said. And you're in this funny position as a dental student where you kind of, you don't have free mind. You're kind of led by what your tutor says on the day. And then there might be a different tutor on the day of fit. And they think, what the hell was this initial tutor thinking? That's life. And that's how it works. Embrace it. Enjoy it. Embrace it. As long as you're there like a sponge learning, you will fly.
Yeah, for sure. Like, I've been frustrated a couple times with treatment plans changing, different clinician, like, pick their brains about it. They'll all have different opinions, and that can be frustrating at the moment, and maybe for the patient as well, but it's like a goldmine of tips and tricks to pick up on. Just
as
pick
long as you keep
brains
asking why, it's so important. So whenever someone changes a plan, that's totally cool. But can you say, hey, Mrs. Smith, like, I see that you changed this from a filling to a crown, or use the other way around, crown to a filling. May I ask the rationale behind that, so I can learn this a bit more, and then just listen and learn, and that everything is justifiable. There's no hard and fast rules in dentistry. You can just justify everything as long as there's a good why and a good reasoning behind it. Yeah,
for sure. And I can't speak for any other universities, but I think dentists that are in education, like, they're all a bunch of nerds. Like, they want to talk about it. They want to be asked why. They love talking about it. So they will stand there and chow your ear off for 20 minutes if you want them to. So.
And you know what? Sometimes they just want, sometimes they just wish that students were more receptive and not on their phone and not, sometimes if you're there to listen, they will give you something. If they suss out that you're actually really keen, they will give you everything. Like, if you show that enthusiasm and keenness, you will really gain a lot. So keep that in mind, guys.
Definitely.
Great. Emma, I hope you have by the time this comes out, maybe after Christmas, but happy Christmas. Happy New Year. And I'm excited to grow together in 2025 and inspire students all over the world. This month's notes were ceramics, right?
Yeah, ceramics, yeah. So those protocols that we're talking about, air abrasion, acid, all those sorts of things, different materials, when not you would maybe use them, all those sorts of things.
Great. And do you remember how many pages it was?
I don't actually. No.
I saw it was very comprehensive, lots of pages basically, but lots of good stuff, very visual, nice protocols. So remember, students, email student@protrusive.co.uk to prove that you're a student. We'll add you to the space and you can access the Crush Your Exam section where all the notes are written by Emma. Any images that we take, we always reference them, which is really important to say thank you to all the people because we know it's difficult to generate these images sometimes, but we always reference where we got them from. And I think what we're building here is a really fantastic resource. So Emma, thanks so much. Keep up the good work and I'll catch you soon.
Perfect. Thank you.
Thank you. Well, there we have it, guys. Thank you so much for listening all the way to the end. As always, thank you to Emma and Team Protrusive. Without the team, I would be totally burnt out. The podcast would have died years ago, but it's down to you guys, your comments, your love, and the hard work and dedication from the team that allows Protrusive to continue and thrive. We got so much planned for 2025. The most happening place to be right now is our Protrusive Guidance app, our community of the nicest and geekiest dentists in the world. That's where you ask your questions that you feel embarrassed to ask anywhere else, and you don't need the anonymous function. There's so much toxicity on Facebook groups, but not on Protrusive Guidance, because you, listening right now, watching right now, the fact that you made it this far, it means that you're definitely very geeky, and you're probably very nice. If you identify yourself as a Protruserati, I've realized that you guys are just amazing people. And so come and join your tribe on Protrusive Guidance. That's protrusive.app to join in. For those of you on a paid plan, you can get your CE certificates. Just answer the questions below within Protrusive Guidance, and Marie, our CPD queen, will sort you right out. Oh, and don't forget to like and comment below. What other topics would you like covered? Thanks again for watching to the end. I'll catch you same time, same place next week. Bye for now.